So what is the damage control resuscitation strategy when we have to deal with trauma patient? The idea is to provide only intervention which are necessary to control hemorrhage, and is to limit the deleterious effect of trauma-induced coagulopathy, and because it could increase the hemorrhage, and it is what we want to prevent. And this strategy has to begin from the scene and to continue through the operating room and the ICU. So the first thing that we have to do in this strategy is to be upset by the fact that we have to stop the bleeding as soon as possible, and we have to not lose time when we have to manage this patient. And first point is that we have to organize the way we take in charge the patient, to organize this during the pre-hospital phase and in the hospital phase. And I want to highlight this on this slide. It's in UK, in London, when they decide to organize and when they think about how to manage their trauma patient in their trauma center. And you can see that just by thinking about organization, about training of the team, you can decrease deeply the mortality in this patient only by organization. So I think that it's the first crucial point to establish when we have to deal with this patient. And the second point is that we have to anticipate. And this is a score that we use in my unit when the pre-hospital team call us and say, for example, I have a shock index greater than 1. We, at this time, before the patient is in the emergency room, we organize we start the different protocol, transfusion protocol. Do we have to insert catheter? Do we have to prepare vasopressor? And so this anticipation is quite important to when you think how I can prevent any lose of time. And you can see that in this red flag protocol that we have, shock index, the capillary hemoglobin, mean arterial pressure, pre-hospital intubation, and pelvic trauma were the item that was most predictive to have to face to an hemorrhagic shock when we have to deal with patient. And when the patient arrive at the emergency room, we have to manage respiratory and hemodynamic failure. We have to perform the EFAST, and we have not to lose very simple things to try to limit the hemorrhage. It could be tourniquet, or it could be also pelvic binder when we have to deal with pelvic injury. So the EFAST also changed really the way we take in charge this patient, because we, by performing the EFAST, we very quickly know where is the source of hemorrhage. The idea is to try to have a clear strategy. To have a clear strategy, it's easy when the patient is stable in an hemodynamic point of view, because you can go very quickly and in a secure way to the CT scan. But when the patient is unstable, you have to choose between going directly to the operating room or going directly to perform an embolization, or going to the CT scan to have to be able to establish all the injuries. And so it's also important to train your team to be able to go to the CT scan even if the patient is unstable, and if you have to continue to perform volumic expansion or to give a vasopressor. The second point is to avoid to increase the bleeding, and there is two ways to do this. It's to tolerate permissive hypotension and to limit the quantity of fluid that you give, and to be very aggressive on transfusion. And so we try to limit the fluid expansion and to have clear target of systolic arterial pressure. Until the bleeding is controlled, it is recommended to have systolic arterial pressure within 80 and 90 millimeters of mercury. If you have a trauma brain injury, you have to increase the mean arterial pressure or the systolic arterial pressure to try to get a good cerebral perfusion pressure. So low fluid resuscitation, it's not no fluid resuscitation. You have to deal with an hemorrhagic shock, and at what point you have to give fluid. But to be concerned about the quantity of fluid that you give. And so you have to limit this quantity to the target of arterial pressure. So it's what we do. It's we perform by successive bolus of fluid of 250 milliliters, and until we reach the level of arterial pressure. And you can see that on this slide, it's in US, in trauma center in US. You can see how they decrease the quantity of crystalloids that they give to a trauma patient. But in parallel to this, they decrease the quantity of crystalloid, but they increase the quantity of red blood cells and FFP. So more and more, what we do is we use red blood cells and we use FFP to give fluid more than using crystalloid. So fluid alone, it's different from fluid with vasopressor. And just to remember you, I'm sure you know this, and so when we have to deal with an hemorrhagic shock, most of the time we intubate the patient, and after we sedated the patient, and by doing this way, we increase the unstressed blood volume and we decrease the venous return. So when we add vasopressor, it's just what we do is just restoring vascular tonus. Given more, when we say that, we decrease the vascular tone, and when we add vasopressor, we restore vascular tone. So we decrease the unstressed blood volume and we increase the venous return. So by doing this, when we give fluid not in a vasodilate bed, but in a vasoconstricted bed, and it's make the fluid you give more efficient to restore the venous return. Just this experimental study where we induce an hemorrhagic shock in animals, and you can see that having two targets of mid-arterial pressure, 50 and 60, when you try to reach this target only by given fluid, we increase the bleeding. If we add vasopressor during the resuscitation, independently of the level of mid-arterial pressure, we have no increase in the bleeding. So I think it's why it's very important to give fluid, but also very quickly to add vasopressor. And this study highlights the fact that when we think about how I can not increase the bleeding, it's more by dilution that you increase the bleeding than really by what is the good level of mean arterial pressure. And we can be concerned about, by given vasopressor, it could be deleterious at the level of microcirculation. And in this animal, we test at the level of intestinal microcirculation. And you can see that when you give vasopressor, it's the density of capillary. You have no decrease in the density of capillary. So vasopressor do not close the microcirculation. So the effects that you have at the level of the venous return are predominant to the potential deleterious effect at the arterial level when you give vasopressor in this patient. So very quickly in my unit, if we have no response after 500 milliliters of fluid, we start vasopressor and we start norepinephrine. The third point is that we have to restore an efficient coagulation, and it's in these European guidelines, it is recommended first to have an early and rapid monitoring of coagulation. And we use more and more viscoelastic method at the bedside of the patient. And also we can guide the transfusion on this bedside method. And it's a study where they try to compare their transfusion strategy. In one group, it's based on viscoelastic method, and in the other group, it's based on conventional method. And you can see it's a small number of patients that in this study, they observe a decrease in the mortality when they guide their transfusion on the bedside method, on the viscoelastic method. So once again, there is limitation in this study. It's a first study showing this, and we need a study with a higher number of patients. But I think it has to push us to use this kind of method at the bedside of patients. So there is clearly two strategies. The first one is what we use most of the time in Europe. It's to give plasma and FFP, and the ratio is at least 1:2. And just to share with you this very now famous study of Holcomb, where they compare two strategies. One strategy is to give red blood cells and FFP in a ratio of 1:1, and the second is to give this compound in a ratio of 1:2. And they observe in this trauma patient with hemorrhagic shock, they observe no change in mortality. But when they look at how they achieve hemostasis, they can see that in the group where they use 1:1, they have a clear advantage to use 1:1 in comparison to 1:2. So it's why it is recommended to you can use 1:1 or 1:2, but it's on this secondary result. Most of the time, I think we can choose to give 1:1. The second strategy, it's it's based on the fact that FFP could have deleterious effect, especially at the level of the lung. And the second strategy, it's mainly used in Europe by a German team. It's based on red blood cells and on fibrinogen. And so they try to prevent any addition of FFP. And there is a recent study where they test this strategy. So it was FFP versus coagulation factor concentrate. And the primary endpoint was multiple organ failure. In this study, they have to stop the study for futility because they, in the group where they give FFP, looking at viscoelastic method, they observed that they were not capable in several patients to restore coagulation just by given FFP. So clearly there is in this study, but once again there is limitation, and we can discuss on this study because in the group where they give FFP, in my point of view, they don't give enough FFP. So clearly in this study there is an advantage to give coagulation factor concentrate versus FFP. And when they look at massive transfusion, once again there is clearly an advantage of given fibrinogen versus FFP, because they observe a decrease in the number of massive transfusion. We need more study, but I think it's interesting to consider this strategy. So the fourth point is we have to be able to manage the combined life-threatening injuries in our trauma patient, and to decide, for example, when we have a brain injury, a severe brain injury, and with a spinal injury, to decide if it's good to go to the operating room to fix the spinal injury, or if we have to wait in the ICU to be sure to control the trauma brain injury, and to don't take risk going at the operating room with an unstable trauma brain injury. And this kind of choice are so important because it could be really deleterious, and is a part of the damage control strategy. So to conclude, I think that this strategy is, the goal is to stop as quick as possible the bleeding, is to try to not increase the bleeding, to be aggressive on the transfusion strategy, and to have a rapid restoration of physiology stability. Thanks a lot.